So today we have a presentation titled Using Pregnancy to Facilitate Physiological Birth and Future-Proof the Health and Well-being of the Family. To do this, Roisin Lennon and Roisin Lennon. Roisin Lennon is an advanced midwife practitioner and has been working in Sligo as a registered midwife practitioner since 2017. She's a member of the midwifery team here since 2003. Roisin provides continuity of care for a caseload of women who would not meet the criteria for midwifery-led care. The extended scope of practice at an advanced level enables her to promote an alternative care pathway for women within the midwifery philosophy of caregiving. Before Sligo, Roisin trained and worked in Scotland as a midwife for many years, and she did her general nursing training in Dublin. Roisin has a special interest in research and audits, aromatherapy, reflexology, and post-date pregnancy treatment. And she is also a IBCLC lactational consultant. Join me this day to welcome Roisin as they take up our presentation. Thank you.
Thank you, Buffy, for that. And thank you to everybody who's joining us today on, especially in Sligo, which is in the northwest of Ireland, an absolutely amazing bank holiday weekend, sitting at about 22 degrees, so gorgeous. So I'm going to do a couple of disclaimers first of all. I will talk about a pregnant woman and talk about ladies, because so far to date, all the people using my service do identify as female, but I know people talk about the pregnant person, so just so I'm not going to offend anybody. And I'd also like to say I've no conflicts of interest. Nobody has sponsored me or done any sponsorship for this. This is just me sharing a bit of my practice. So can I get the next slide, please, Bucky? So conference today for the Midwifery International Day of the Midwife is Midwives Making Connections. So when I saw the theme, I thought, I know exactly what I'm going to talk about. Talking about weight gain and pregnancy and physical activity, because this has come from me using my lateral thinking, changing practice, doing a little bit of problem solving, and just in response to what I came across within my daily practice. So next slide, please. So in Ireland, we certainly work within the HSE, which governs our practice, and we do a thing called making every contact count. And it's a way of doing health promotion, starting off conversations and trying to share all that. And as an advanced midwife practitioner, I take ladies through their pregnancy journey from about 20 weeks or so postnatal. I don't provide interpartum care, but it just means there's probably about 250, 300 ladies in Sligo every year come through my pathway, and they can get their care within that midwifery philosophy. So great, love it, it's so nice. You get to know the women, you know if they're not well, they've got contact with me in between their visits, and I love it. I love being a midwife, and I have to say, being an advanced midwife practitioner is just fabulous. Anyway, when I started my service in 2017, one of the things that I did do in the first visit when I'd meet the lady was talk about her weight gain and pregnancy. And I'd say to them, look, you've got about 15 kgs to play with, but if you put on more than 20 kg, that's going to increase the chances of your weight going up, your baby's weight, your blood pressure, and increasing your chance of a section. So it was one thing we signpost to healthy eating and all the rest. However, during COVID, wonderful COVID, in the lockdown, in the May 2021, I noticed I had 12 emergency caesarean sections in a 6-week period, sorry. And in that time, 31 babies weighed in at more than 4 kg. I'm like, oh, something going on here. When I looked at the ladies, they may be booked with a booking weight of maybe 70 kg, and these ladies on the bed were maybe about 110 kg. But put on my thinking cap, I thought, look, what are we going to do? When I started midwifery back in the dark ages of 1991, the women were weighed at every visit. Now, I know back then that weight was to look to see if they were developing preeclampsia. As time went on, and I'm going to say about 1997, because I know I was pregnant with my daughter then and I wasn't weighed during the pregnancy, they stopped weighing. certainly at that time, we noticed when everyone was getting weighed, babies were coming in about 3 to 3.8 kgs. Once we stopped weighing, suddenly babies are coming in a lot heavier. They're coming in at maybe 4.5 kgs. We came back to Ireland in 2003. Women were getting weighed. Their babies were weighing 3 to 3.8 kgs. So I thought, right, okay. Then when they stopped weighing in Ireland, similar to Scotland, the babies were getting heavier. So right, let's do a literature search. Let's see what the literature is saying about this, because maybe we could do a bit of weight gain, weighing in pregnancy, bringing out that healthy eating and everything. So I looked at it. Nice guidelines, as we all know, well, those who work in the UK and Ireland, they recommend calculating the BMI at booking. If the BMI is over 30, then discussing healthy eating habits, physical activity, and referring them to a dietitian. Now, I know in SIGO, even the ladies with BMIs are over 40, the dietitians just can't see them. So I thought, right, okay, that's that. Then there was another study, and it said that actually there's insufficient evidence to look at weight gain in pregnancy, but that if the women are aware of their weight gain, then they're more likely to develop healthy eating habits and make their changes in their diet. Then Canalcard, he looked at stuff and he was linking with the literature increased weight, increased chances of preeclampsia and blood pressure, cesarean sections, and large gestation age babies. Mardones et al. In 2021 and Karang et al. In the same year, they looked at excess weight gain and they looked that there was ongoing postnatal obesity, there was ongoing weight retention, and then more chance of diabetes mellitus in later life and cardiovascular disease. They also noted that the babies to women that put on excess weight had more fat stores and this predisposed these kids to then childhood obesity and blood pressure early on in their life. Feely et al. In 2021, I think, or 2022, which is a little bit later, but I just bring it in. There was no consensus about weighing in pregnancy or what the weight gain was, but that in Australia, they have moved back to routinely weighing ladies and using that for health promotion discussion. So put all this together and I thought, you know something, let's think about weighing ladies in pregnancy again. Nothing to lose for that. So can I have the next slide, please? So very simple. What I did was I changed, and instead of saying that kind of 15 kg, I started talking about that they actually need 50 calories extra a day. That's all. We all know it's about 500 when they're breastfeeding. So most women are quite surprised when you say to them 50 calories. So they're going, whoa, okay, I'm not eating for 2. And you're like, no, you're not. And then bring it into play the Eat Well plate and the food pyramid. So looking about, stacking up on your fruit and veggies and minimizing your high fat and your high sugar content foods. And into visualizing it for each lady. So having that 5-minute chat, enough time to explore. Can I get the next 2 slides, please, Bucky, just to go on to the one for the Institute of Medicine. So the Institute of Medicine in the UK and the next one, they have devised sort of based on your book and BMI, what your weight gain is in pregnancy. So just the next slide again, please. So for me, with my little 15 kg, what we do know is that ladies who are sitting with a BMI over 30, they have 5 to 9 kg to play with. Now, for most ladies, what you're talking about is from 34 weeks onwards, it's about half a kilo a week, because that's when the baby's laying down the fat stores. So again, just calculating what that lady's BMI and sharing that information with her. The other thing that I meant to say as well was on the reverse side of it all, for gaining weight, ladies that don't gain weight then in the last few weeks of pregnancy, and actually that weighing, so I have had 3 or 4 ladies that their symphysis bundle height has been more or less equal to their gestation in centimetres, but they hadn't put on weight. So I've triggered scans and I've actually picked up 3 or 4 small for gestational age babies. So again, you don't want to be getting these small babies there. So as you can see, not a lot of room to play with for the ladies that are that bit obese, but great for just talking about portion sizes, healthy eating and all the rest. And pregnancy being such an ideal opportunity. Women want to do stuff for the health and well-being of them and their babies. Also bring it into it the first 1,000 days. So again, that whole idea from conception, what the mum eats in pregnancy, that the baby gets a liking for as well. So if mum's eating healthy, they like to think the baby's got that taste, mum's going to keep those habits going forward. And then that's the health and well-being of the family, hopefully making a bit of a change coming forward. The other thing that I forgot to say was that Ireland actually has the highest obesity rate in Europe. So like that was interesting as well. So again, an ideal opportunity to use my health promotion and that chance of pregnancy to maybe make a few changes. So next slide, please. So again, with the whole service, I've always talked about physical activity in pregnancy. Now, I don't like using exercise because then people think they've got to be doing a whole pile of extra, serious training, but just something that's going to get them to move. A lot of the time I'll talk about 3 or 4 crazy dances around the kitchen to a good song with our toddler. And bearing in mind that the World Health Organization does recommend it, they're talking about 20 minutes a day or 150 minutes a week. We know the benefits are things like that it can improve mental health. And most of the time, the ladies that actually do exercise and keep it going in pregnancy are ones that have found already that that is great for their mental health. And there's probably about 50 to 60% of my caseload do have pre-existing anxiety and depression on meds, maybe not on meds. Also, we know it reduces leg cramps, improves our sleep pattern, reduces the chance of postnatal depression, reduces the chance of excess weight gain, and can minimise then induction of labour and all the rest. So really nice little bits, very simple. Again, just individualising it, tailoring it to that woman. So next slide, please. So then what we also have is, and Sinead Thompson in the National Maternity Hospital in Dublin, she was training for her marathon many years ago. And at the time, her trainer said to her, but sure, you're used to devising training plans for pregnant women. And she said, no, we don't. So she went off and she thought, that makes sense. Putting in together fetal optimal positioning, health and well-being, bringing forward all the work from way back when, and also when people were active and you were out, doing your vegetable patch, out scrubbing your front step on all fours, doing things that we don't nowadays because we've got that really sedentary lifestyle. So labour hopscotch, really simple visual tool that starts at the bottom square, moving up to the top where you've got the 2 squares with the baby's feet as well, and use it as an antenatal preparation. But also then when you come in labour, you're not going to sit back in labour and just be a passive and just let it happen. You're going to remain active and be an active participant and helping the baby negotiate the pelvis. So you can see it's broken down into 20-minute segments. So if we go to the next slide, please. These are the 3 squares that I focus on with the ladies at the clinic. So I talk about the 20 minutes on all fours because we're meant to be 4-legged creatures, and being 2-legged creatures, as we know, has given us all this lovely pelvic girdle pain, OP position babies, all the things that are just not conducive to a nice physiological onset of normal labour and birth. We're tying that in with things like rebozo, Mexican start technique, just optimizing that baby, hopefully lining it up in the center of the abdomen, doing lunges, doing massage, doing squats, doing walking, mobilizing the pelvis, just basically keeping the pelvis nice and mobile, keeping the posture of the lady good, getting her doing a physical activity and hopefully getting that baby into a good position for labour and birth, and working on the birth control from kind of 25, 26 weeks. So moving on from that then, so next slide, please. I had the pleasure in September 2022 doing a training day with Molly the midwife in biomechanics for pregnancy and birth. And all the bits that she added into it and talking about the rebozo, the posture, lunges, squats, sideline releases, all the rest, actually making sure that then the pelvis doesn't have any roadblocks or any great big muscle spasms and the baby maybe isn't a bit sideways, can actually enhance the chances of onset of spontaneous labour and helping the baby negotiate the pelvis during labour and birth. I thought, this is just amazing. So, lovely visual toolkit. Let's add this into all the ladies here as well. And sorry, I should say the labour hopscotch since I think 2020 has been rolled out to all the pregnancy units in Ireland, and it's also including all the antenatal education. So like the women are getting that. So next slide, please. So what I noticed was then when I had added in the fetal optimal positioning, was I suddenly thinking, oh, something, I'm not having to organise inductions as much. Women are coming in, even the Paris ladies, very few ladies of 40 weeks at the 5-5 palpable head at the brim. They're going, okay, this is maybe working. Let's have a look. Let's get the stats from before I brought in that extra little bit of the biomechanics and see what was happening. So what you could see was before I started introducing all these extra little bits, there was only 33% of ladies had had their babies by 41 weeks. My induction and labour rates were nearly 43%, which was high. And the induction labour emergency caesarean section rate is 33%, with an overall total caesarean section rate in my group of 20%. And that would include ladies that are on the Robson 5 categories. So I take ladies that have had a previous section and are hoping to have a vaginal birth. So, you know, that was high, but 33% emergency section is not great. So what I was looking at then, on top of all of that, was 44% of the ladies, of the babies, were born more than 4 kilos. And that was linked in with 80% of the women that had gained excess weight gain of pregnancy. And then there was none of them had increased blood pressure. Now, there was some had, but not those that had the excess weight gain. And there was about 2% that landed up in the neonatal unit that had excess weight gain. And once we brought in all the bits with the biomechanics and everything, that went down to 0%. So next slide, please. And I thought this was really just summed up what I was achieving and what I wanted to do with it all. And it was, I am no longer accepting the things I cannot change. I am changing the things I cannot accept. So I couldn't accept that women were putting on excess weight, not eating healthily, not exercising, not doing physical activity, so changing it. So next slide, please. So as we know, if we do any interventions, we have to audit it. You can't just change it. You need to look at it and then say, right, this is working or it's not working. And if it's not working, what can you do? Share the findings within the unit and then develop your quality improvement plans. So did the interventions work? Next slide. So you can see on the far left was the pre-intervention. So before we added in the biomechanics, we were already doing the hopscotch. We were already trying to make sure the weight gain was within the IOM recommendations. So you can see a huge difference. Like, isn't that just amazing? Simple, getting people up and walking, and bearing in mind at the same time, our national guideline came out that said women should be induced to 41 weeks, but women can wait to 42 weeks if they so wish. So again, just trying to get them in, that induction of labour isn't happening because that's increasing the caesarean section birth rate, but also just changing everything. So as you can see, my induction rate, it did go down, but it hasn't gone down great, but it's gone down a good 20%. I would have a caseload of ladies that have maybe had previous preeclampsia, previous cholestasis, large gestation age babies, shoulder dystocia. So these ladies are being induced around term. But still, just to take it out of the equation and to reduce then the emergency caesarean section birth rate from it all is good as well, because again, then future-proofing, not having that whole VBAC discussion then if you can have that normal birth. So again, just, you know, really nice, showing very simple interventions that they actually work, but also showing that it wasn't just a blip the following year. They were continuing to do what I was hoping that they would do. So next slide, please. So conclusions then, it's very simple. There were simple interventions, making connections, using my skills as being like that advanced midwife practitioner, doing health promotion, a very captive audience that want to change things for themselves and their family, optimizing physiological birth. And I'm not one of these midwives of physiological birth at all costs. That is not me, but it's, you know, if you can get that, and empowering the women to make decisions, using that shared information sharing, decision making, coming to a plan, it makes such a difference and the women appreciate it. And again, just reduce the emergency sections overall and reduce the emergency sections when induced. Now, did I manage to roll it out within the unit? Unfortunately not. And I think just some of the consultants felt that if we were getting women weighed the whole time, they would see that as a target, and some of them would be putting on 20 kgs or more, which I didn't see. They do all get the labour hopscotch. They get the biomechanics of the antenatal education, but a lot of the times it is the first-time mummies that are getting the education. They're not always, the second-time ones maybe aren't, so they're missing out on that little biomechanics bit. But again, we're just trying to spread the word, just trying to normalise it, make a difference. We certainly verbally from ladies, their pelvic girdle pain isn't as bad, and especially if it has been bad in the pregnancy, that baby's tucked into the pelvis by about 36 weeks, so they actually have a very comfortable last couple of weeks of their pregnancy. Okay. What else did we do? So take home message, I'm just saying that it's very ideal opportunity to encourage healthy eating and physical activity. It's all robust information they're getting. Now, it probably works well through my service because they get that continuity. I'm like that little earworm that at every visit, you know, how are you getting on? They're getting weighed. And sometimes I forget to weigh a lady and she automatically goes stands on the scales herself. So they actually want to do it. I've only had one lady that has been very heightened anxiety from being weighed. And even for all of that, then the last time she came, she was standing on the scales. I said, no, you're not going on the scales. That you're really, really upset about it. So no, we'll leave that. On the whole, most ladies, they do keep within that weight gain. Sometimes they put on excess. And sometimes when I first meet them at 26 weeks, they've got on nearly all their weight. When you explore it, so for one lady, when she was pregnant, her partner used to bring her home a muffin every day as a kind of reward system. When she realized that muffin was 600 calories, she's like, whoa, no, not happening. And they started going out walking every day and they gave themselves a little reward chart. And if they had managed so many minutes of exercise and they treated themselves to maybe go to the cinema one day during the week. Another lady, she actually put on excess weight, but when I explored with her, she was a chef, struggled with her weight all her life, would only eat one meal a day. But because she was pregnant, she was eating 3 meals a day. She was eating healthily. She was eating all the right foods. So again, it was like going, right, okay, we're not going to keep weighing you. You're eating healthy and that's, you know, what you're needing to do. And like I said, then the few ladies that didn't put on weight, we picked up 3 or 4 small for gestation age babies that if we hadn't picked them up, I might have let them go to 41 weeks before we induced them. And then you would have had a little 2.5 kilo baby or problems. So it's very simple. It could be rolled out across everywhere. But the whole idea is that just using it as that long-term investment to try minimize that excess pregnancy weight gain, that they don't have that ongoing obesity postnatal and that weight retention, and also minimizing then the health and well-being for babies moving forward, that they don't have that childhood obesity. So that's me. I hope that makes a bit of sense. Thank you so much for listening. And if anybody has any questions or comments or discussions, I'd be very happy to chat through them. And I actually should have said I did get to weigh or not to weigh in pregnancy and bouncing your way to labour and work using biomechanics and fetal optimal positioning were both published in the British Journal of Midwifery. So if you want to do a little bit more reading into it, they are available online through that magazine.
Thank you very much. Thank you, Roisin, for the beautiful presentation. So we take a few minutes to take questions. You can respond, you can ask your question in the chat box. Ask your question in the chat box. Roisin will respond to them. Any question, idea, comments?
Somebody put in, Catherine James, she just asked, so yes, the ladies prior to the intervention, there was 33% had birthed their babies by 41 weeks. And after the first year, it was 91.8, and I think then 82%. So just that was a great change in that alone, just to take that induction of labour out of the whole equation. And I don't see any other questions there. I don't know.
Any other question for Roisin?
Oh, how many mums?
How many mums?
Yeah, I would have about 300 ladies would come through my service each year with about 200 to 240 remaining on the pathway. So it was most years similar numbers. So, you know, 240 or so. So quite a few.
Okay. Any more questions? There's a question for you, Roisin.
So low cost intervention with undeniable benefits and likely cost savings. Absolutely. And I think I can get away with murder a bit because I'm the older, fatter midwife that, you know, you can bring up that conversation in a very non-judgmental way. And again, that whole making every contact count, you can bring it up by starting, look, I've noticed that at your booking, your BMI was 38. Would you like to talk about, you know, healthy eating in pregnancy or physical activity. And, you know, there's never been any barriers to it. Like I said, there's only one lady that got really upset that she'd put on nearly all her weight at the first visit, and she was still, you know, really just trying to work around it, but trying to reassure her that she was eating healthily. Well, sometimes when you explore with the ladies, they're doing like the jumbo bag of crisps and they're eating the whole lot. So when they take the 25 gram, put it into the bowl and realize that that's their portion size, it's very simple to change it, and visual is great. So, no. And like I said, I'd love to see it, that it could be rolled out throughout the unit. Medical pressures, no, it just hasn't been adopted within the rest of the antenatal bit. They get weighed at their booking in appointments just to calculate their BMI, but they don't get weighed again moving forward from that. And like I said, the labour hopscotch is throughout the 19 maternity units in Ireland. And within that labour hopscotch, it does take into account lunges and rebozo and mobilisation and the ball work. And that's all bits that Ollie, the midwife, that she uses in her biomechanics as well.
Wow. Thank you very much, Roisin, for the beautiful presentation. And